Bismillah Rahman Rahim. Assalamu alaikum. Dear colleagues and PGs, we are discussing chronic hepatitis C. In the previous videos, we have discussed the structure of hepatitis C, whereon then its life cycle, then the evolution of the different treatment options, the landscape. We learned that we started with the interferon, then ribavirin was added to the interferon, the standard interferon, then was the pegylated interferon in riba combination till 2011 or 12, when the first generation of DAAs, the boceprevir and telaprevir, they were marketed, and then for genotype 1, they were given in combination with pegylated interferon for genotype 1. Then later on, the semiprevir, it was marketed, and again with pegylated interferon, it was given for this hepatitis C. Later on, the interferon-free regimen came, and now the riba-free regimens are being discussed. The current or the latest additions to the DAs, they are pain genotypic, and nowadays we don't do genotyping because we are having the pain genotypic drugs available with us, which are effective across the all genotypes, genotype 1, 2, 3, 4, 5, 6. In today's video, I shall be discussing with you that what are the treatment options available for us in Pakistan, and how we should go about, and what should be the treatment strategy, and what options should we offer for our patients. So, as I said, today's video is about the HCV treatment regimes. This is the table from the EASL guidelines, and this table is showing the products, their presentations, and the dosages. Like in the pain genotypic drugs, the sofosbuvir, it is 400 milligram tablet, and it is given one tablet daily. Then the sofosbuvir hepatitis combination, it's a combo drug where the sofosbuvir is a 400 milligram and velpatasvir is 100 milligram. Again, one tablet daily is the dosage. This is the soft velpa and voxilaprevir combo pill, in which the sofosbuvir is 400 milligram, the velpatasvir is 100 milligram, and voxilaprevir is also 100 milligram, and it is given one tablet once daily. This is the GP, and where the glecaprevir is 100 milligram and piopentasvir is 40 milligram, and these are given 3 tablets once daily. Similarly, the other genotype specific drugs, their combinations is being given. In this table of the EASL guidelines, this is showing the interferon-free, riba-free combination treatment for treatment naive patients, treatment experienced patients, and those without the compensated cirrhosis. And these are the pain genotypic regimes, the soft-well, the GP, the soft-well, voxy, and genotype-specific regimes. And these are the different genotypes. Similarly, this table is telling the again the normal liver patients, either treatment naive or treatment experienced, and the different genotypes, and the pain genotypic drugs, they can be used in all these genotypes. Similarly, soft-well voxy is not recommended because of the availability of these very effective regimes over there. And this is the table showing the patients with compensated cirrhosis, that what options should be there. What I will do in the Pakistan scenario, we are having a predominantly genotype 3, rather now the 85, 90 or 95% of our patients, they are genotype 3. And even then, with the availability of the pain genotypic drugs, what should be the treatment options? So when a patient comes to us with chronic hepatitis C and we want to treat, there are two main decisions which we should do before starting the patient on treatment. First of all, what's the liver status of that very patient? Whether the patient's liver is normal or it is fibrotic or cirrhotic child class A. And how we come across the patient liver status? By the APRI and FIB score, as well as if the availability of the fibroscan is available by the fibroscan transit elastography measurements, and of course the ultrasound. So if on the ultrasound the liver is perfectly all right, there is normal texture of the liver parenchyma, there is no splenomegaly, there is no portal vein dilatations, and we do the APRI and FIB, and they are saying that the patient is having normal liver, or if we do the fibroscan and it tells that the patient is having normal liver, zero fibrosis, or F1 fibrosis, insignificant fibrosis, and if our patient is fibrotic or cirrhotic. In the cirrhotic patient, child class A, so we divide the liver of the patients into two main groups, the normal liver and second, the fibrotic or cirrhotic child class A liver. And the second decision, what we do, whether the patient is treatment naive or treatment experienced. If the patient is treatment experienced, what was the previous antiviral treatment, whether this was the interferon or this was the interferon and then DAs, the initial DAs, that was the soft riba, or the it was the interferon and soft riba combination. So this is important, and or if this was the soft riba and DECLA. So depending upon the previous treatment, what was that treatment, and whether the patient's liver is normal or fibrotic and cirrhotic, we devise the treatment strategy. The commonly used drug is the soft DECLA combination. So first I will discuss with you what treatment regime should be given in these patients. If your patient's liver is normal, you check that with the APRI, FIB4 ultrasound, and ideally, desirably, with the fibroscan. If the patient liver is normal, a patient is treatment naive, no treatment was given, neither the interferon nor the early DAAs, and you are using soft DECLA. So this is the green group patients, and you give the soft DECLA for 12 weeks. So in this group, normal liver, treatment naive, soft DECLA for 12 weeks is sufficient, and it will give you more than 95% of the SVR rates. But if the patient is treatment experienced, and this was either the interferon treatment was given in the past, or the soft riba combination was given in the past, then, and you want to give the patient soft DECLA, then add riba into it, and it should be soft DECLA and riba combination for 12 weeks. So the difference between the treatment naive and treatment experienced patients with normal liver is that with a normal liver, treatment naive, you give soft DECLA for 12 weeks, and with treatment experienced, you give soft DECLA and riba for 12 weeks. Now coming to the second class, or accordingly the liver, if the patient's liver is fibrotic or the patient is cirrhotic child class A, and you want to give the soft DECLA, so it should be soft DECLA and riba for 24 weeks. So it should be clear that this is the third difficult case. The most easy to treat is normal liver with treatment naive. The second bit difficult is the normal liver with treatment experienced, and relatively more difficult is fibrotic or cirrhotic child class A liver and treatment naive. And if the patient is fibrotic or cirrhotic liver and treatment experienced, here the soft DECLA combination is of no use. Either these patients don't respond, or if they respond, they relapse. So the soft DECLA combination is applicable in these three groups. And as you go across, you add riba and you give the combination for 12 weeks. And here you give add riba and give the combination for 24 weeks. So this is the way the patient should be treated. especially from in the institutions where the soft DECLA or soft RIBA is available. This is the way it should be given. Now coming to the soft well option, if you are treating these patients with soft well, what should be the drugs combination and duration? In normal liver and treatment naive patients, the soft well for 12 weeks is sufficient. And if your patient is treatment experienced and if the previously used treatment was interferon, then probably soft well for 12 weeks will be sufficient. But if it was the initial DAs like soft RIBA, or if the patient is non-responder or relapses to the soft DECLA, then better that you add RIBA into it. And the patient should be now given the soft well RIBA for 12 weeks. So the difference between these two with normal liver, if it is treatment naive, soft well for 12 weeks, but if it is treatment experienced, then soft well RIBA with or without RIBA for 12 weeks. I personally use RIBA in each and every such patients who is treatment experienced, irrespective of whether this is the interferon experienced patient or this is the relapsers, the non-responders to the soft RIBA or soft DECLA. I give this group the soft well RIBA for 12 weeks. Now coming to the fibrotic or cirrhotic liver in child class A, if the patient is treatment naive, so definitely this is the soft well RIBA for 12 weeks. So here it's the soft well RIBA for 12 weeks. But if my patient is fibrotic and cirrhotic and the patient is treatment experienced, so again I will be using the soft well RIBA for 12 weeks. But I have seen a couple of patients, right, good fraction of the patients who are non-responders to this soft well RIBA combination or soft well combination. So in this case, I may extend the therapy to 24 weeks. This is not in the guidelines, but on the personal experience, I may extend the therapy to 24 weeks of the soft well RIBA for 24 weeks if it's the most difficult. Because regarding to the therapeutics, this is the most easy to treat and this is the most difficult to treat group. Now, if soft well and RIBA is not an option and you want to use the soft well Voxy, but it's not indicated in the normal liver. It's indicated in the fibrotic or cirrhotic liver, either treatment naive or treatment experienced, because in the treatment naive and normal liver, its efficacy is the same as the soft well. So the soft well Voxy, it can be used in the treatment naive, especially when the patient has got fibrotic or cirrhotic liver and the patient is not eligible for ribavirin or patient cannot tolerate ribavirin and you want to treat that patient, then soft well Voxy is an option here. And of course, if the patient is fibrotic or cirrhotic and the patient is treatment experienced, again the soft well Voxy is an option here. What I personally use, that I treat these patients, most of my patients with soft well without RIBA and with RIBA, and again with RIBA. But when my patient is relapses a non-responder to soft well with or without RIBA, then I go for the soft well Voxy in that very patient. So this is the way I treat these patients. Now another option, that is the GP option. It depends upon which group you are treating. For normal liver treatment naive, you give this GP for 8 weeks. For a normal liver and treatment experience, to give GP for 12 weeks. And the same you give GP for 12 weeks in the fibrotic and cirrhotic liver. But if the patient is fibrotic and cirrhotic and it's treatment experienced, then you give this GP for 16 weeks. So dear colleagues and PGs, you must have noticed that from a treatment point of view, we classify our chronic hepatitis C patients into 4 groups. The normal liver and treatment naive is the most easy to treat, and all these options available, the soft decla, the soft well, the GP, the RABA is not needed in this group. And if this is soft decla or soft well, 12 weeks is sufficient. And if you are using the GP is not available here in Pakistan, but if at all it is being used, it is for 8 weeks is sufficient. And the most difficult group is the fibrotic cirrhotic group and treatment experienced. And here you see the GP is given for 16 weeks, soft well Voxy for 12 weeks. And if this is soft well RABA, I will be personally using for 12 weeks or maybe for 24 weeks. And you see in this group, the soft decla is not the drug of choice, and I have never used the soft decla RABA in this group. This is the most difficult to treat. Then difficult but less than this is the fibrotic or cirrhotic liver with treatment naive, and you see here that the duration and the RABA is required and duration is increased. And this is the bit difficult but less difficult than this group, the normal liver and treatment experience. So when a patient come to you for the treatment of chronic hepatitis C, and you have decided that you want to start these patients on treatment, you should put the patient into these 4 groups. Either this is the most easy to treat, or this is the most difficult to treat, or it's in between. So the color coding, the green, the yellow, the orange, and red is very, very important in selecting the regime as well as the duration. And remember, if you are using the soft decla in the red group, this is not the treatment of choice, and better you go for the soft well and RABA. Personally, I'm using the soft well Vexi for these soft well relapsers and non-responders. I have not used the GP in any of my patients for the simple reasons because it is not available here in Pakistan. The soft well Voxy, it is available in Pakistan now, and it is costly as compared to the other drugs which are quite cheap. A monthly cost for the other drugs, the soft decla and the soft well, is around 6, 7, 8,000 rupees, and the soft well Voxy it's expensive. It's in 3 lakhs or something like that is the total cost. So that's the reason I put this drug only for those who are the soft well or soft decla non-responders. But what I do, that if my patient is non-responders to soft decla, I start these patients on the soft well RABA for 12 weeks, and I don't jump directly to the soft well Voxy in this patient because almost all of these patients who are relapsers, non-responders to soft decla, the soft well RABA does give the results. So dear colleagues, I hope that I have simplified for you the regimes of the hepatitis C treatment, that what treatment should be used and for what group and for how long duration. So I stop here and we meet in the another video in the future. Thank you.